I'm going to test this out. Oh, this is a heavy microphone. Get my reps in here. So you know a little bit about me, a little bit about what I'm going to talk about today. I'm really hoping that Dr. Fink, who I have not had the pleasure of meeting as yet in person, makes it here because she has the unique viewpoint, medical viewpoint in terms of the female athlete triad. But I will do my very best to make sense of her slides as we go through. We sort of integrated our presentation. But before we start, I want to talk to you a little bit about eating, okay? About weight loss, and the way just in general, as non-sports people, just as humans, we deal with that. How many people have ever talked to someone about their weight? Okay? How many people have ever asked, do I look like I've gained weight? Do I look like I've lost weight? Okay. That's everybody, right? And when we consider athletics, we are multiplying that experience tenfold because we are, as athletic people, that's great, athletic people. As people who are involved in athletics, that's part of what we do. Not me personally, but all of you. That's part of what our job is to look at and look for signs of health and signs of fitness in the people that we're working with, the students that we're working with every day. So it happens on a general level, and it's tenfold when we're talking about athletics. Okay? And I'll give you one example of sometimes when we think maybe we're doing something really good, and it ends up actually making things a little bit worse. And it's something that I would venture to say that all of us have done. A little self-disclosure about myself, about 3 years ago, I finished up losing about 80 pounds, which is the size of an Olsen twin, approximately, okay? And when I would see people that I hadn't seen in a while, yes, she's coming, yay. When I would see people that I hadn't seen in a while, I got this reaction. Oh my gosh, look at you. Ah, you look great, everything's great. It wasn't, you look healthy. I even got, are you okay? Right? But they hadn't seen me in a while, so it looked like it had, happened overnight, but it took, over a year. And so we have this reaction when we see people who have lost or gained a lot of weight. We have this just regular, usual reaction. And the problem is that can really highlight what a person who's struggling either with the symptoms of or a full-blown eating disorder, it highlights what they're afraid of. They're afraid that other people can see changes in their body. And for most of the people who have eating disorders, even though there's a growing population of men, they are predominantly women. It highlights this body focus and this fear of gaining weight, right? This fear. We talked about anxiety in the beginning of our day here. And it really is a phobia. Some people conceptualize eating disorders as a weight phobia. They're so afraid of the number even. Not the way the clothes fit, not the health issues, but the number. I happen to have a student in one of my classes right now who is struggling with an eating disorder. I happen to know for a whole bunch of different reasons, all the hats that I wear at the school where I work. And she came to me and she said, I was going to come to class, but I got on the scale in the morning, and I knew I shouldn't get on the scale, but I got on it anyway, and I just couldn't come. Once I saw that number, I just couldn't come to class. And because it's the fear, because it was a half a pound or 0.4 more than she wanted, more than she expected, she couldn't do her day. And that's not atypical. That's pretty common. Among people who are suffering, again, either with a diagnosable disorder in terms of meeting all the criteria and symptoms, or if we're just talking about someone who is sort of on their way, engaging in some of the behaviors that often lead to a diagnosable kind of condition. Okay? So I'm going to try to delay a little bit longer here. Maybe I'll skip some stuff on the way. But what we're going to try to talk about today is the types of eating disorders that there are, the female athlete triad, which has been renewed in the medical literature, in terms of something that happens to female athletes in training when they have disordered eating, amenorrhea, which is the loss of their menstrual cycle, and eventually osteoporosis, bone disorder, bone disease. That's why with Dorothy Fink, when you were talking about her bio, she treats athletes with stress fractures because their disordered eating and their lack of nutrition has gotten to such a point that their body is literally breaking down. And we may not see broken hips or things like that. We might see in older people, but we are seeing these athletically related bone injuries and stress fractures. So we'll talk a little bit about that and how to treat that, as well as some of the psychological treatments that are available. And then if we have time, we'll try to take any kind of questions that you might have about this. Excuse me. What I was saying to Noreen before we started was that sports and athletic personnel always seem to want to know not really the facts, right, but what can we do? And I would try to give you a little bit of that as well. And I think the take-home message is you have to be able to recognize the signs. And I think that was part of the couple of the first presentations, is recognizing when someone gets on the road to disordered eating. Because it doesn't happen overnight. Just like anxiety doesn't happen overnight, and depression doesn't happen overnight, suicidality doesn't happen overnight. It's a process. So if we can recognize people, athletes, students, when they're on the road to these problems, that's when we can intervene. That's when we're going to have the most success, before it really gets to a place where it's out of control. Okay? So there are 3 disorders in this category. You probably heard of at least 2 of the 3 of them, I would think. They are anorexia nervosa, bulimia nervosa, and binge eating disorder. I'll talk a little bit about what each one of them is. The most common disorder among student athletes, females, and the one that contributes most prominently to the female athlete triad is anorexia nervosa, which is really the restriction of food intake. I read a story a couple of years ago. A student athlete was training for a marathon and was very happy because yesterday all she had to eat was a cube of cheese. So whatever you put on your salad today, maybe those little pieces of mozzarella, just one for the whole day. So we're not talking about cutting down. We're not talking about cutting back. We're not talking about limiting carbs or limiting sugar or something like that. We're talking about restricted eating, little tiny non-nourishing types of items. Okay? Binge eating disorder is least often talked about, and that's mostly resulting from stress. Yay. She's here. Yay. Mostly resulting from stress. And I have a short video that I want to show. If you could just click that link for me. And I only want to play till like 3:16. No, come up here. It's okay. Come up here. We're going to play a little video. Sorry, that's okay.
To stand up, it overtakes us completely. The current in an endless pool pushes us to be stronger athletes. It keeps us from ever touching the wall. And when we try to stand up, it overtakes us completely. As athletes, we spend our lives trying to beat the current, to tough it out, put our heads down, keep swimming. Since I was 6, I wanted to become an Olympian. I had many successes along the way, both in the pool and out. I spent nearly 16 years chasing that Olympic dream. but I never did reach it. Swimming is like most other sports. It lives and dies by measurements. Our successes and failures are defined by numbers, one by one. The distance practiced, the number of strokes. And in turn, I defined myself on numbers. I was convinced that if I figured out the right formula, reached the goals that I set, I would in turn feel good enough, accepted, comfortable in my own skin. I had it all, including a secret. When I would achieve success, it was either not good enough or just a step towards the next goal. Eventually, the measurements of success turned to measuring waistlines. My weight. Counting calories. And ultimately, purging. I wanted to reach out, to say I was struggling, but instead, I suffered in silence, fearful of judgment. I'd always thought that struggling was a sign of weakness, that I had to tough it out, and that being mentally tough meant putting my head down, trying harder, and swimming against the current. But the harder I tried, the weaker I became. The current became too strong. I couldn't find my footing. I couldn't fight it. Not alone, anyway.
We'll return to that story a little bit. Anybody have any comments or thoughts about it? I chose it because I think it sort of encapsulates a lot of these things that we've been talking about today. Not only disordered eating, in this particular case talking about more bulimia nervosa and purging, but about anxiety, about depression, holding it in and being fearful that a person would be judged. We have to create a climate where the student athletes know that that's not going to happen. They're not going to be judged. They're going to get help. If we can do that, then we've made a big stride. So in terms of the disorders, we've talked about those. And now, oops. Oh, I lost my ability to advance. Okay. Bulimia is known to affect approximately 2%-ish of women. Less men are afflicted with bulimia. It is increased, this is in the general population, it's increased in the athlete population. And most men who experience eating disorders are athletes. There's not that much incidence of eating disorders in males in the general population. It exists, but it's a small number. So we're talking about mostly male athletes there. Okay? And now it's your turn.
Thank you so much. You're welcome. Hello, everyone. I'm sorry that I'm late. I actually had a dancer this morning in my office who is 30, so she's well beyond the years of students that you're working with, but she still struggles with an eating disorder. She's still dancing, but my heart goes out to her because I see her for her amenorrhea, which we're going to get into in terms of the female athlete triad. So I see her because she's not having regular periods still. She's 30, and her bones look like my 80-year-old patients. And I always say to myself, how can we intervene during the crucial years of adolescent years and teenage years when these athletes are really forming and looking to become the best of the best and looking to be any way they can adjust, their inches, as we just saw in that video, or different aspects about themselves so that they can make it into whatever group that they want to be in. So unfortunately, I had to send that woman to the emergency room because she had a really low blood pressure and heart rate. And now we're going to talk a little bit more about the female athlete triad and how we can hopefully work to identify that with all the young athletes that you're working with, so that they can attain a peak bone mass, which means the best bones possible, so that we can prevent fractures and keep them at optimal bone health and just health in general. So I want to talk about the female athlete triad. It was first described in 1992, and its association of the following: disordered eating, amenorrhea, meaning no periods, and osteoporosis. Now, that has been updated in 1997, and then again more recently, because we have found that it's not that someone has no periods at all necessarily. It's not that someone necessarily doesn't eat any food at all, and it's not necessarily that they have the osteoporosis of an 80-year-old at the age of 17. But it is true that a lot of these young athletes have some form of disordered eating. It may just be restricting one food group. A lot of them will say, I'm gluten intolerant. I have, this gluten allergy, but they've never been tested. Some of them will say, I'm allergic to dairy. Some of them will say, I'm just a vegan, I'm a vegetarian. And they pick these different food groups to just essentially cut out of their diet completely, and it leads to an energy imbalance. The next component is the menstrual dysfunction. So a lot of women won't lose their periods completely. I often find that they'll say, well, when I'm in this intense period of training, my period goes away, but then it'll come back in the summer months when I'm off, or in between times of training. So it doesn't have to be complete absence of periods, but it can definitely be irregular periods. And then, of course, for our male athletes, they're not going to have a period as the sign, but they can still have the first one, the energy availability issue. And then the third component is the bone mineral density. And I often check this in patients just because we can look at the Z-scores to compare that person's bone density to the age-matched controls to help them to see how their bones compare to people the same age as them, and it can help them realize that they might be already affecting their bone health. Okay, and then I'll just say one more quick thing, and that ties into this slide too. So what I think is really important about this is that it's a spectrum. So you don't necessarily have to have all three parts of the triad, quote unquote triad, but some people will have low energy availability with or without an eating disorder. And it can go along that whole spectrum to optimal energy availability. Same thing with periods. They don't have to be fully without a period. There's in between subclinical menstrual disorders, and same thing with the bones. A lot of people, and I've seen a number of young athletes who get stress fractures, their bone density looks normal, so it doesn't. You don't necessarily see the long-term effects of their energy deficits right away, but they still have this acute caloric deficit in relation to how much energy they're putting out, and it really sets them up for stress fractures. Next slide, please. Thank you. So basically, what we have mentioned, so the negative energy balance exists in these young athletes. The expenditure exceeds the intake of the energy they're putting in, and that's how I describe it to them too, because oftentimes when I'm meeting someone for the first time, I'm not going to immediately say, okay, clearly you have an eating disorder, because I want them to come back to see me and not think that I'm going to put them down a road of something. So it's this hard balance, but I try and frame it as there's an imbalance. You're putting so much energy out and there's not enough energy in. And I even tell them that it's really easy on days when you're in school and then you're running to practice and you're trying to do all this, that you may think that you're eating, but actually you're not eating enough because you're not taking time out to eat a meal because you're either in a class or studying or in practice. So that's kind of talks about the energy balance and how it can either be a problem with the energy intake or a problem with excessive amounts of exercise. And then for women, basically, I tell the young women, I say, look, you're unlikely to be looking to get pregnant at this moment in time, but your body if you went through menarche, meaning you started having a period, your body can sense that when it's in a state of low energy, the first hormone to go is your reproductive axis, because your body knows that if you can't take care of your own body, there's no way it could handle another person. So that's why the pituitary in the brain, that gland completely shuts down so the ovaries don't get stimulated at all. Okay, great.
You see why we needed her? Psychology, I got nothing on that. Okay. So what does this look like? Before we get to the point where, again, we're talking about trying to intervene earlier, as early as possible. So what does this look like in the beginning? Now, we all might feel that there are some things about ourselves that we don't like that much, but we're talking about a clinical level of body image distortion, where someone is seeing themselves, just to put it in terms everybody hopefully can understand, is seeing themselves as a size 14 when they're actually a size 2, or a size 0. So we're not talking about little differences. We're talking about big distortions in the way they perceive that their body looks. Typically, we will see someone start with an eating disorder as someone who goes on a diet. Eating disorders often start with a diet. Not always, but often. And so, as athletic professionals, as trainers, as coaches, sometimes we're putting our athletes on diets because they need to lose a few pounds or gain muscle mass in order to perform better. And so that could be where it starts. It would be a little bit crazy of me to say that, well, then you shouldn't do that. I don't think that's the case. But when we're going to suggest that somebody engage in a healthier eating lifestyle, we need to call it that. A healthier eating lifestyle, not a diet. Because then we become focused on weight loss or weight gain or sizes, and that's where the disordered eating can come into play more. Okay? Often the transition occurs after a stressful event. Big shocker. Same thing for all the other things we've talked about today. Something that was under the surface, just barely there, just jumps right up out of the water after a breakup or a loss or an injury or something like that. So when student athletes, people are most vulnerable is after these events for whatever it is that we're talking about. So we want to be looking out for them at that time. The group we talked about earlier in terms of getting together once a month to talk about injury and recovery, that's a great thing because that's when people are most vulnerable for, again, whatever we're talking about. Many people do recover. I know a lot of stuff we've talked about today has been kind of depressing, right? There's so much bad things happening out there. But some people will recover from a disordered eating episode. They stop starving, they stop binging, they stop purging, and they recover. Those that don't, however, end up with these really lifelong injuries and lifelong problems. Okay? A person who, usually a woman who's showing up with an anxiety disorder, eating disorder like anorexia, doesn't just have disordered eating. Very often, mental health conditions occur in clusters. And so an isolated case, I'm not sure that, I've been in practice for almost 20 years, I'm not sure that I've ever seen an isolated case of just one problem. Someone might have mostly treating disordered eating or mostly treating depression, but they're also dabbling in substance use, or they're depressed, but they're also having symptoms of disordered eating. So it's not something that can be seen as a single cause, a single treatment, but rather this cluster of symptoms that often occur together. Oh, I just want to say one more thing. Probably the highlight, if you had to pick one thing to pick out someone who is likely to get an eating disorder, particularly anorexia, over someone else, it's that last thing there, perfectionism. That personality pattern, somebody who, they had 14 block shots in the game and the scorekeeper only has 13, and they have to have that corrected right then. They can't wait till tomorrow or later. It has to be corrected right then because it's not right. It's not correct. And not just about sports things, but about everything. They will argue on a test they got a 96, but it should have been a 97, right? That perfectionistic tendency is one of the leading predictors of development. Medical problems, I think this is
Sure. Alrighty. Okay, so we're going to go through some of the medical problems that can occur with anorexia nervosa. So we talked about the amenorrhea, the no periods or somehow irregular periods. And then these are a lot of the symptoms that my poor patient had this morning. So basically, your body just shuts down. So like I talked about how in women their body shuts down so that they're not stimulating their ovary to make an egg each month and then subsequently have a period. Everything shuts down. So I tell them their heart shuts down, all these different organs shut down. So their temperature is low, their blood pressure is low, they can get swelling. We talked about the bones, their heart rate goes down. They can definitely get electrolyte imbalances, meaning the potassium and a number of the other different blood levels of things that we can measure can be off. They can also have dry skin, nail changes, and then lanugo, that's this very like soft hair that can grow on, you can see it on the cheeks sometimes of patients with eating disorders. Another finding that was on my patient today is they tend to often eat a lot of vegetables, so they can have an orange hue to their palms. It's called carotenoderma. So people who, I have a number of dancers who literally like live on carrots, they will look orange. So that's for the medical problems for anorexia nervosa. And, oh great, thank you. And then in terms of switching back to the different forms of irregular periods, I think that the biggest take-home point for you all is that when a woman goes through menarche, which is the first period of her life, it takes a couple years for their cycles to get in check. And I'll have people come to me when they're 19 and be like, oh, you know, I'm still young, it's normal for me not to have a regular period yet. And that is not necessarily true. Usually within 5 years, they should definitely be having a period every single month. So when you're seeing them in college, by that time, they should not be blaming being young and not having a normal period on it. So that's that. We can sometimes get formal with all these different definitions, but I think that the major takeaway home point is that the cycles really shouldn't be longer than 35 days in college-age students. And then this is just interesting in that it kind of breaks down the populations in terms of who is most at risk for having these irregular periods. And then it's also interesting to break it down in terms of the age, and then, of course, looking at the prevalence of eating disorders in athletes versus the general population. And then when a patient comes to me and they're coming to see me for an irregular period, you know, the most common cause for what the athletes that all of you are working with is going to be that they have an energy deficiency, right? That we talked about, either they're putting too much energy out or not putting enough in. But we, of course, think through all these other things that are on this list, because even though the hypothalamic amenorrhea, which is basically the no period from exercising too much, that comes into play there, but these are a number of other reasons that someone can just lose their period, and that's why we examine all their different hormones to look for other reasons, because it can be another reason that they're having these symptoms. Okay, and then in terms of thinking about the different sports that can most increase a person's risk for these types of presentations are really any sport that really emphasizes is being thin and lean. So a lot of long distance running, ballet, gymnastics, but swimming, I mean, there isn't necessarily one sport that we can exclude, because of course there are people that defy the definition. So look out for this in all the athletes. And then what I think is a really important thing to bring home to all of you is that where you're going to see these presentations is not going to be potentially not going to be the athlete that comes to you to be like, hey, I'm not getting my period. Probably not the most common topic that comes up, but it's going to be that they have a stress fracture. And usually, when you think about what is a fracture, you'll think, oh, well, a hip fracture is bad, a spine fracture is bad. Those are the typical, like elderly woman, male fractures. But the fractures that you all are going to see more frequently than a spinal compression fracture that can occur in athletes that are young, but not as common. But the ones that I see the most are stress fractures. So you're going to see these foot stress fractures, and they're going to be like, oh, it's just my foot, I'm fine. But really, I believe that like seeing a foot stress fracture in a young person is this huge harbinger of what's going on at the level of all of their bones, not just one small bone in their foot. So that is something to really think about, and that this female athlete triad with these hidden eating disorders really sets them up for fractures that can truthfully change their entire career pathway when something like that happens and takes them out of a season. Okay, so let's switch back.
Okay, I think, are we done at 1:45? So we're just going to run through maybe just a few more of these and leave some time for some questions. Again, you probably know from popular literature there's this difference between these two kinds of eating disorders. Both not good for your physical health, certainly not good for your energy level or your training as an athlete. Bulimia nervosa tends to have more external results. Starvation and reducing calorie intake or food groups can really damage your bones, as we've seen, and other things. Bulimia, because of the behaviors that take place during an episode, causes problems mostly with your gastrointestinal tract. You're most likely to see people, mostly women again, who are purging after meals and are affecting, that behavior is affecting their throat, their esophagus, their teeth, and their tooth enamel, their taste buds, all kinds of things like that. The problem is that behavior becomes typical. And as much as we might not want to think about that, particularly right after we just had lunch ourselves, it becomes something easy and not at all disgusting to a person with this type of disordered eating. So the more they do it, the more likely they are to continue to do it because it doesn't bother them. One of the problems with this is that most people, especially the friends of the person with this bulimia type, they know that that's what that person is doing every time they get up after a meal and go to the bathroom. They know it. They come back, they're chewing gum, they have mints, they know, and they don't say anything. It's that point, early, again, before we're getting to the point where it doesn't bother the student at all to do that, where somebody's got to say something. What are you doing in there? Calling them out on it. Intervening in some way, in a supportive way, of course, but in some way. And most likely what happens is we just ignore it. We just pretend it's not happening. Somebody else will say something. And they become very good at hiding it. So if you see it, you have your opportunity to intervene at that moment. Okay? Same kind of excessive exercise, other methods besides vomiting to induce weight loss, including the use of laxatives we talked about before. And I won't even go into some of the stories about efforts that people have taken to rid themselves of the food that they just ate, especially because we all just ate. Okay? Again, higher cases among athletes, most likely occurring in females. The main difference, again, is in the behaviors and also in the fact that people who have bulimia are more likely to be normal weight, normal or just slightly above normal, even at the point where the disorder is the worst. It's not working. What they're doing to try to lose weight, it doesn't work. It may work for a while, but they're going to bounce back up. Okay. Again, starts with dieting. Again, medical complications, same kind of thing. I don't know if you want to speak to this at all. We said most of this stuff already about the stomach acid damaging your gastrointestinal track. This is all on the slides if you wanted more information about it. Certainly could read. Binge eating, you don't see as much. It's not as common. It's basically the binging part of bulimia without the ridding yourself of that food part. And we see that sometimes. Lots of potential causes for eating disorders. Again, most likely to occur somebody who is on a diet, who is focused on their body, like a student athlete, who then experiences some sort of stressor. Again, the problem is that it doesn't just go away on its own. Typically, the person is going to require medical treatment or psychological counseling or something in order to change these behaviors. And it can be difficult for many reasons. One of the reasons being, of course, that there is this shame factor. So I'm going to drive that point home again, that we have to create, for mental health in general, these environments where athletes, student athletes, don't have to be afraid to talk to their coach, to talk to their professionals in the athletic department, or whoever, to direct them towards the people who can help them with these problems. Oh, and the end of the video is very nice. Can we play that? It should be queued up, but if it's not, we need to, of course it's not.
Not alone, anyway. After some encouragement from a friend, I met with Barb, the sports counselor for the athletic department. After a few sessions, I learned coping strategies to deal with the constant pressure of measurements. Barb helped me raise my head from the endless current. I lost my footing here and there, but the people around me helped pull me out. One of my biggest fears was telling my coach, the disappointment, the judgment. But instead, I was met with overwhelming support and guidance. For him, asking for help wasn't a weakness. It was a strength. I'm still learning how to find my identity outside of my sport, but I'm not letting a measurement, a number, or a time define who I am. Maybe one day I'll open a pool of my own, and I'll teach the lifeguards one thing. Look for people drowning on the inside.
Your mental health is just as important as your physical health.
Don't suffer in silence. Our doors are always open.
Okay. Alrighty. So basically, I think the biggest point to drive home that what I want to do with all of you today is to say, okay, well, if we have people who have energy imbalance in their lives, how do we fix it? And there are many ways to approach health. A lot of health care in general, when I see it today, not just for what we're talking about today, but in general, it's a Band-Aid. We just throw a pill at something to be like, fix it, I'm fine. I don't want to have to think about what the underlying problem is. And the underlying problem for these athletes is that their energy balance is off, so we have to restore the balance. So that means working with a great team, and the best outcomes that I've had with the athletes that I work with are when they're seeing nutritionists, psychologists, have really supportive team coaches and trainers, and also doctors who really care about not just their lab or the pill that they're giving them, but think about what's going on with them as a whole person. So getting that energy balance back is key. One way you could look at it, though, is to say, oh, well, your period's off, just take this birth control pill. You'll get a period every month. And the number of women that come to me saying, well, I get a period every month, and then I ask them, well, what medicines are you taking? And then they're on a birth control pill, and I say, well, you know, the only reason why you're getting a period is because you're putting fake hormones in your body every month. So you're getting an artificial period, which is not really what your body is making on its own. So I think that the best way that I've helped women when it comes to their periods being irregular is to tell them that their period is kind of like a blood pressure for an old person, right? It's like a barometer that we check, and if they're getting a period naturally every month, that means that their body is communicating between the brain and the ovaries, and it's working. But if someone is just thrown on the pill, and they're not actually told that they have to eat, and they have to cut back on the intensity of their exercise, you're going to just be in this vicious cycle that never gets fixed. So I think something, though, that's important, and what I tell women is that, even when you start eating more balanced, your period's not just going to come back like that, because the body takes time to recover. So I love this slide. This is from the Female Athlete Triad Guidelines from 2014, and I show this to patients all the time, that we recover your energy status first, which is going to take time, but then over time the periods will come back over months, and then over years the bone density can come back. And I've definitely had young women who are still in that time of peak bone mass accrual who have kind of gone off the curve, but they can get back on it when they change their lifestyle. Let's see, yes. And then, do you want to comment on, okay. Okay, sure. Okay, sure, and then, yeah, I don't know if I take it. But I think, though, I want to say that working with a psychologist and a psychiatrist to really address the underlying eating disorder is so key in all of this. And sometimes that requires inpatient admission, as was on the last slide. Sometimes it's just a lot of outpatient work, which can totally be done. And this is what I had already mentioned, is that we really need to target the energy availability and not just throw hormones at it, thinking that we're going to make it look like the person is fine when they're really not. So those are the main things. You can review those in your in the slides if you have any questions. And then this kind of goes through some of the unique ways that doctors can work to treat the eating disorders. And then that takes care of it for us. So we're happy to answer questions. So feel free to ask.
Time for one question. We have the next panelist is there and ready to go. Anyone have a question?
I wish I knew that. The only thing I can really say to speak to that is to encourage not only new recruits but current student athletes that there is this continuity and community of care. That the health and wellness that you have in high school should only get better as you are in college, and that we're not going to leave you out to dry or on your own. I can't, if I said that 10 times a day, every day, I don't think I would say it enough. That we have to let them know that they will be taken care of. How exactly you do that, I don't know.
Very tricky. What I will say is that I don't have the perspective of Jen in terms of working directly, on site at a college campus, but I do get tons of patients sent to me from many different undergraduate programs and different dance programs in the city. And I think that something that is really striking to me is who undercovers a lot of these things and finds out what's going on. And I found that a lot of it isn't necessarily definitely orthopedic surgeons, they're great. They noticed some of the things, but a lot of it is the athletic trainers who are with these athletes moment to moment. And I have found that some of the best outcomes I've had are when I'm in constant communication with the trainer and they're telling me, look, here's what's happening with this person. And when we can see and identify from that trainer working with that person every day, they can pick up on things, or just like small talk here and there between people. And so even if it's not necessarily part of the recruiting process, if once they're there, they can really pick up on things early and can get them the needed care sooner rather than later.
Great, thank you again, and to properly introduce and thank Dr. Fink. Thank you for making the trip out, even with the emergency you handled this morning, and I really appreciate your passion for this area. And if you have questions, we've given email addresses, so hopefully you will be open to communication in that regard. So thank you so much for both of you, and for you starting solo. Thank you very much.